cool slicing. Production value is going to go through the roof. Okay, so our goal today is I'm going to run you guys through a kind of a summary of what we've done in lab, highlighting some of the points, and then answering some of the questions that you guys sent to me. I've kind of either done slides specifically for the questions or just kind of melded them in. If there's something else you want me to cover, let me know and I'll do my best. Cool. Did this. Oh, yeah, so this is the kind of the general, I did not fix the bottom one, pardon me. This is the general kind of what we're gonna cover. So our targeted cardiac assessment we learned cardiac pathologies, so differentials and treatments. We talked about rapid trauma assessments, and that's supposed to be injury cataloging and treatments on the bottom, but I didn't change the slide. So we learned how to assess people and fix them. And then in trauma, we learned how to assess them and fix them. Cool? So a cardiac assessment, that's the red side of our assessment. We haven't probably looked at this in a long time. So when do we do a cardiac assessment?
Chest pain?
Sure, chest pain, I love it. When else could we do a cardiac assessment?
It's just like, it feels like so much can just come back.
Yeah, anytime, anything, yeah, that's great. So like dizziness, weakness, shortness of breath, lots of things can make us be like, this could be your heart, because your heart's connected to everything, right? So on that note, some chief complaints: chest pain, shortness of breath, nausea, vomiting, weakness, syncope, just generally feeling unwell. We can kind of think about cardiac. Run me through my cardiac risk factors. Smoking, drinking, men,
High blood pressure.
High blood pressure.
Cholesterol.
high cholesterol, what was that one? Stress, yep. Old age, sedentary lifestyle,
Previous.
family history, yep.
Previous heart attack.
Yep, drinkers, the diabetes, yep, the sugar diabetes. Yep, congenital heart disease, yeah, so a lot of those cardiac conditions, fantastic. All right, so what are the pathologies that we're trying to fix? What are the ones that I'm gonna test you on? Unstable and stable angina, I love it. CHF, yes. MIs, yeah. Cardiogenic shock, yeah. You're gonna have to speak louder.
Pulmonary embolism.
Thank you, pulmonary embolism. Or I think that's all of them. Sounds right? That feels right. Feeling right. Okay, so ECG interpretation. A couple questions on ECGs. These are the rhythms that I expect you guys to be able to read. Should be the same ones that Greg has. Is there anything I'm missing on that list? Yeah. Is there any of these that you guys are like, I've never heard of that before in my life? I would hope not. Is there any of these that, like, what are your thoughts on this list? Does anyone think they couldn't read all these ECGs?
Would SVT be on there as well?
It would be, yes, SVT should be in there. Thank you very much. Let's talk about SVT for a second. So what is SVT? Great. So what does the word supraventricular mean? Yeah, anything above the ventricles. So SVT, God damn it, Brandon. SVT is like an umbrella term that covers a whole bunch of rhythms. So SVT could be sinus tach, could be A-flutter, could be AFib, could be like a junctional rhythm, could be an accelerated junctional. Yeah, but it's going, the problem is the reason we call it SVT is it goes so fast that we can't see a P wave. So we can't figure out which of these it is. Because you need a P wave, you have to be able to see the P waves to figure out is this A-flutter or AFib or junctional or sinus, like what am I looking at? So when it gets up higher than, the old school number used to be 150, but that's not a great number because age dependent, health dependent, yeah, it's not great. But when it gets fast enough that I can't tell if it's a P wave, we would start calling it SVT. Does that make sense? Cool. So SVT, we'll put SVT here because we're thinking it's a separate rhythm. But just so you guys know, SVT is actually like a collection of rhythms. So we don't know what it is, but it's going so fast, we're just gonna call it SVT. Cool. there's a good chance you could see all of these, like on CPSA. They're not gonna pop up for like a stupid reason, like I'm not gonna put A flutter there just because, and not have it have any relevance. Like we had AFib on the neuro CPSAs, because it was relevant. God was an AFib, he was having a stroke, throwing clots, like it tied into the history. So I'm not just gonna put a 3rd-degree heart block there for absolutely no reason. There would be like a history reason why, maybe he had a previous heart attack, and that's the other reason I'm trying to get you to catch it. I'm not gonna throw a 1st-degree heart block there just cause, that would be silly. But yeah, you should be able to read all of these rhythms. So everyone's cool with these? I don't have to talk any more rhythms? Great, this is gonna go fast today, I love it. Okay, so besides reading the rhythm, so my expectation is that you guys will read the rhythm for the cardiac patient especially. Trauma one I'm less concerned about, but the cardiac patient especially, you'll be able to read the rhythm and tell me what you're looking at and do it correctly. Cool? You also should be able to find the MI. I found this one, it just seemed really cool. You guys have heard PALS before? Right? So posterior, anterior, inferior, lateral, septal. And if you think it's an anterior, your reciprocal changes are the 2 letters that are next to it. Everyone knew that?
Wait, say that again?
Haha, okay, taught you something. So if you're having an anterior MI, so ST elevations in your anterior leads, which are V3 and V4, correct? Where would you see reciprocal changes? Posterior, and oftentimes you'll see it in the inferior, because the way that it could be anterior going up to the left, like more of the left side, so you'll often see it close to the right. So when you're looking for posterior changes, if it's an anterior MI, you would see reciprocal changes in your posterior and inferior leads, possibly. If you had a lateral MI, you'd be looking for inferior and septal, like depression. Does that make sense? I've never ever seen isolated septal MI, like an MI just right here. Usually, it's just the way the vessels work, you usually will come with like septal anterior lateral. Like you won't often just see a septal MI. Never heard tell of it, but I'm sure it can happen. So I wouldn't freak out trying to find like just elevation in V1, V2 by itself. It usually comes with something else. Cool? How's everyone? Yeah.
So if we had a non-STEM,
Great.
let's say we had an anterior, or no, we'll go easy, we'll go inferior and STEMI.
Wait now, how do you know it's, okay, let's talk about that term. Can I
That's
erase
what
this?
I'm trying to figure out. If you have, so you're not gonna have ST elevation,
Mhm.
but if you have the reciprocal depression,
Oh, I know what you're trying to do, okay.
yeah.
You took a little bit of a leap of logic on me. So you can't work backwards and say ST depression is telling me where the like DMI is. So it doesn't go the other way.
Doesn't go the other way.
So when we're talking about MIs, we'll use the term OMI. You guys heard this term before?
No.
Occlusion MI.
Oh.
It just basically means STEMI and NSTEMI. And the reason, like, if you do any reading on current literature, you'll see this term comes up because there are like STEMI mimickers. Has Greg talked about mimickers at all? You might have said it in one slide. There are other things besides MIs that can cause ST elevation. And there's different rules, so like if somebody has a left bundle branch block or a pacemaker, those always have some elevation. So there's rules that we can use to figure out if it's actually an MI. This is probably above what you guys need to know. I think what's fair for you guys to know is if somebody like don't just rely on the ECG. If somebody presents like they're having a heart attack, give them aspirin Netra. Cool? If you're ever unsure, we'll just go with that. So, a STEMI is an MI, so occlusion MI is just like a heart attack. A STEMI is one that has ST elevation. An NSTEMI is an MI that doesn't have ST elevation. Reciprocal changes, like you have to have ST elevation in order to have reciprocal changes. You can't have reciprocal changes by themselves. Does that make sense?
Yeah.
So when you see SD depression by itself, you can't say that it's an infarct. You can't say that it's an MI. You could say that it's maybe some changes caused by ischemia. So SD depression can cause ischemia, which could be from an NSTEMI. It could be that the heart muscle is dying and it's not showing, it's not picking up where it's actually dying. So you can't, just to kind of summarize it, you can't use ST depression to figure out where the MI is. The only time you can tell me where the MI is, or where the heart attack is if you have ST elevation in 2 leads. And then the reciprocal changes, Kyle made the point a couple minutes ago saying that sometimes he sees waves on rhythms and it, like, I don't know what this is and it's confusing. ST depression or reciprocal changes are kind of like that. If we see ST elevation, but Jesus, there's depression down there, it's just helping us kind of shore up the diagnosis and going, oh yeah, no, I would expect depression down there. That makes sense. Does that make sense what I'm telling you guys? Cool. So again, my expectation for CPSA next week is that you guys have a patient, you get an ECG, you can tell me the rhythm, and you can tell me where the MI is. So if we have an anterior MI, so elevation 2, 3, and 4, with or without reciprocal changes, because not everybody gets them, you should be able to tell me that it's a sinus tach and there's an anterior MI there. Cool? I will have some flexibility, so if it's an anterior lateral and you say anterior with lateral involvement, or you say anterior and I'm not sure about the lateral leads, like, sure, I'm not a hard ass. Not that much of a hard ass. If you say, if it's an inferior wall MI and you call it anterior, then it's probably a fail. Because they also have like different things to consider, right? Inferior wall MIs are often low and slow, they have different presentation. So I'm expecting that you can tell me where the MI is. Cool? Awesome. So some pathologies, I think we've covered them all in the kind of list we just did. Stable versus unstable angina. So stable angina is the patient who I always get chest pain every time I shovel. And he goes to shovel and then, oh look, I got chest pain. Like that's stable angina. I guess the other part to that is it goes away like it normally does. So I always get chest pain when I shovel, I sit down and take a spray of nitro and I feel better. So when that happens, that's stable, that's perfect. You probably won't see much of that in the field. I think I did one sim with a group, or a couple groups where a guy lost his nitro. That's the only one I can think of where somebody will call you for stable angina. Or maybe it's the first time a family member's seen it and they freak out. But usually stable angina, they're fine. They do their own thing. When they call us is when it hits unstable angina. So I always get chest pain when I shovel, it goes away when I sit and take a spray of nitro. I start shoveling, get chest pain, I sit, take my spray, it doesn't go away. Okay, now that's unstable angina. Or my chest pain always feels like a little bit tight right here, but now I'm feeling it's really heavy I can't feel my arm at the same time. New symptoms, unstable angina. So, or, I'm trying to come up with another one, I always get chest pain when I shovel, now I'm getting chest pain when I light up a cigarette. Okay, so something new is causing it, the chest pain feels different, or the chest pain's not acting like it normally does, that's unstable angina. Can we tell the difference between unstable angina and NSTEMIs? No, not us in the field, we need some blood work, right? And that blood work can take like 24 to 48 hours to show up, depending on like what we're testing. So we're gonna treat unstable angina like an OMI, like an MI. So out of this list, like 2 of them kind of go together, exact same treatments. Cool? Make sense? To go back to the terms you guys are familiar, you can't tell the difference between an NSTEMI and unstable angina. Not in the field, it's the exact same thing. So we treat them both like they're a heart attack and we just carry on.
If they were having unstable angina and they were resting or sitting or whatever when you got there and their symptoms started to resolve from rest, would you still treat it like an NSTEMI?
I probably would. So again, we're calling it unstable because their chest pain gets better without rest. Or let's do the story, shoveling, I usually get better when I rest and take 1 spray. Now I've had to take 3 sprays. I'd probably still bring them in and call it unstable angina. I'd figure out why it's getting worse. If nothing else, that patient could probably benefit from like a physical, like a once over by a doc, some new blood work, and seeing if their cardiac health is deteriorating. So they would benefit from like a checkup, if that makes sense. But yeah, anytime you have chest pain that doesn't act like it's normal chest pain, or doesn't resolve, or presents different, or has a different cause, we're gonna treat it like an NSTEMI. Cool? And how do we treat NSTEMIs, or any MI for that matter? Aspirin nitro. What's the dose of aspirin? 280 milligrams to 281 milligrams, so 160 milligrams PO. What are some contraindications? Shed leads, asthmatics, yep. Allergen, yep, hypersensitivity.
Said you use for 6 hours.
Is that for aspirin as well? Okay. I thought it was just for ibuprofen, or for Toradol, but okay, I trust you. I believe you.
I could be totally lying too. I'm not the brightest.
Sure, I love off-topic questions.
I never got the allergy myself.
I know, I called Kaylee, she's on holidays until today, she's supposed to call me right back. I'm absolutely, I'm gonna CC you guys in the email next time, so it looks like there's 50 people like looking for it.
I'm gonna be like, yeah,
I have been trying, I've called her 3 or 4 times to get her in EMS after you guys. I forgot, yeah, it's not. Kyle's been active, so.
I was gonna prod you again, Dan. You probably.
No, I did, I called her.
I was surprised I said.
No, it's all good, no, yeah, my bad day, doesn't mean you can't ask me questions. I did call her, I did send her another email, cause she said she was supposed to be back in the office today, and I think she's lied to me. If I don't get something like by tomorrow, I'm just gonna go up to her, not her house, but to the office and be like, hey, give me the code. Cool, so that's STEMIs. My expectation is that you can find the STEMI, that you can understand that not all MIs have ST elevation. So you can tell the difference between unstable and stable angina, and you know how to treat them. So aspirin nitro, oxygen as well, as needed. Cool? Yeah? That's really quiet. Pulmonary embolisms, how does that present different than MIs? Pinpoint chest pain, shortness of breath, yeah, usually shortness of breath is more of the complaint. What do you got there in the back?
Is it refractory to O2?
Yeah, so they don't get better with O2, so SATs don't rise with O2, awesome. Sometimes they get some pulmonary edema. What's some relevant risk factors for PEs? What kind of risk factors cause PEs?
Sedentary.
Yep, so sedentary, specifically like for a long time, right? Yep, recent travel, that's the sedentary piece, right? But you can also get it in like people who, they've broken their leg and they're bedridden. And they can't like move their leg. So it happens in hospitals sometimes. Well, yeah.
Surgery.
Yeah, so they've had a surgery, yeah, recent surgery. That's why you're often put on blood thinners like after surgery. So you don't have clots floating around where they're not supposed to be.
Hormonal medications like birth control.
Birth control, hormonal medications, excellent.
High cholesterol.
Smoking, high cholesterol, all the other cardiac ones fit there, right? DVT, yeah, there you go. So that's a physical one we come up for. We feel red hot calves. I love it. Treatment. How are we treating PEs? Oxygen, yeah. If you're not sure if it's a PE or an MI, you can give the aspirin. You can try nitro. They might get real sick from it. So just be ready for that. Does that make sense? So if you have some, like, our patients don't read the textbook. So he does, like, the old lady who's having PE doesn't realize that she's supposed to say pinpoint chest pain to make you guys think of PE. They don't realize that, right? So she might say, yeah, my chest just feels funny. It's just weird. Yeah, I don't know if I call it pinpoint, I'm not sure, maybe, I don't know. So they can get kind of wishy-washy between PEs and NSTEMIs. These can get kind of wishy-washy. So if you're not sure, aspirin's not gonna hurt them. It's not gonna make them any worse. If they've got good blood pressure, they can probably tolerate that spray of nitro. Just careful they don't have like signs of right-sided heart failure, because they'll get hypotensive from it.
So if they like don't have signs of right side heart failure and they have it, and we give them nitro, that wouldn't be a fail, or would that?
If it's an obvious PE,
Yeah.
so they're saying these words like pinpoint chest pain, yeah, then I would expect you guys to know that,
Yeah.
right?
But if they're saying like,
Yeah.
oh, my chest feels weird, and
Correct.
I don't know if it's a PE
Correct.
or an NSTEMI.
On your CPSA, this is more of a helpful advice for real life.
Yeah.
On your CPSA, I'm not trying to trick you. So if it's a PE, it'll be a very obvious PE. If it's an MI, one of these, unstable angina, which kind of, they all fall into that OMI category, it'll be obvious. I'm not gonna give you like stupid ECGs that don't make any sense. I'm not gonna give you rhythms that don't make any sense. I'm not gonna give you the really weird, like, odd presentation of an MI. It's gonna be like good presentation. They might have to be MI, like, the female presentation, and I do that because it's just how we did stupid research when we decided male versus female presentations. But like that no chest pain, like just more general nausea, for the presentation of an MI. I might give you that one, but I'm not gonna give you like, oh, my toe hurts, and they're having an MI. Like, that's dumb, I'm not gonna give you those, I'm not trying to trick you guys. Does that make sense? Cool. Psychological safety all fits, right? Honest assessments, honest testing, all of those good things. Let's talk about heart failure. So I've had a couple people come up to me about heart failure. What's heart failure?
Inability of the heart to maintain adequate volume of perfusion.
Yeah, so it's your ability, can your ventricles push blood forward? So, where does your left ventricle push blood? Yep, so it goes out your aorta. Left ventricle goes out your aorta. So if your left ventricle can't push blood forward, where's the blood back up? Lungs and the pulmonary arteries, right? So when you have left-sided heart failure, it usually presents with crackles, right? Because the fluid's backed up into your pulmonary arteries and starts to leak into your lungs. Right side of your heart. Where does your right side of your heart push blood? Great. Where does it get the blood from? Yeah, systemically, your vena cava. So if your right side of your heart can't push blood forward, it can't push it into the lungs, where does the blood go? Systemic. So what does that look like? JVD, pedal edema, pitting edema is a better term, because it'll go to the lowest spot. So if you found somebody, little old lady's on the toilet, she has a syncopal episode, she's in heart failure, and her feet get stuck up in the air, her feet probably won't swell, but her hips will. Does that make sense? Or if they're on a stretcher for a long time, and like some of the stretchers, you're gonna have their feet elevated. If their feet are elevated, you might notice that their feet aren't as swollen as you'd expect, but their hips or their sacrum or their butt is kind of puffy, like compared to normal. Careful saying somebody has a puffy butt though. It's not gonna work.
What about the sideways?
You can get abdominal, yeah, absolutely, yeah, because we'll back up to your liver, so you can get abdominal like distension, liver distended, so you can get into. There's some assessments where you like, it's called like Murphy's sign, similar to Murphy's sign. Where you put your fingers on the ribs, so you get them take a deep breath in, and like put your hand there, and you can feel the liver margins. You can feel the liver's kind of swollen up. Yeah, that's a great one. Yeah, you can see some ascites there as well. Absolutely. How does left-sided heart failure cause right-sided heart failure?
The right side is gonna work against the increased pressure.
You mumbled. I think you said it right, but
The
you
right
also
side
like
has-
kind of copped out by saying it quiet, so no one else can hear
The
you.
right side has to work against the increased pressure in the pulmonary.
Yeah. So we've got me and Andrew are working in a factory loading boxes onto a truck. Andrew passes me a box, and then I take the box and put it into the truck. And then all of a sudden I fall down, and I can't move the boxes anymore. So Andrew has to pick up the box, but also throw it into the truck. So the right ventricle, if the left ventricle fails, the right ventricle now has to work double time to try and make up the difference. And if you look at the heart, most of the muscles on the left side. So we got a little skinny right ventricle that doesn't have a whole lot of strength. We probably should have switched this because you're definitely stronger than I am. So me and my little spaghetti arms, I can't throw a box into the truck from the building. So the right ventricle can't push blood from the right ventricle through the lungs, through the heart, down to the feet and back up. So that's where it starts to fail. So you start getting pulmonary edema with the swelling in the feet. Does that make sense? And the ascites, that was a good catch. Cool, does everyone understand that? Does anyone need me to draw it out, or? This is gonna be really quick if you guys are.
Can you draw an app?
I can, yes. Here's your heart. We got your aorta, your vena cava. This is the part where it gets kind of weird. So this goes to a pulmonary artery, and then I'm gonna draw your aorta down at the bottom. Just it's not where it is, but then all the ins are on one side and the outs are on the bottom. And then you got pulmonary arteries. So we've got a vena cava right here, and a pulmonary vessel, and then your aorta. Again, I know that the aorta isn't at the bottom of the heart, but this makes the drawing a little nicer. So blood fills up your right ventricle, and that pressure that's putting blood into your heart, what's that called? Preload, right? So when we give somebody nitro, it can make this vessel bigger, so it can decrease their preload. We'll tie in why that might make a difference in a second. So right ventricle, or right heart, you could say, pushes blood out to your pulmonary vessels. If it can't do that, maybe there's too much blood in there already, or a COPD patient who's got pulmonary hypertension. So that means these vessels are getting smaller. Or somebody's got a tension pneumo, it's starting to develop. That's why you see JVD when you get tension pneumos. It's kind of like a short-term right-sided heart failure, because it can't push against the extra pressure on these vessels. So if the blood can't go forward, it starts to back up, and we get JVD, we get, just because I said it, puffy butts, and feet, as well as ascites in the stomach. Cool? We got your left heart. So assuming this is working well, blood's gonna come in from your pulmonary vessel, and it's gonna go out your aorta. If we have hypertension, just regular hypertension, aorta smaller, the systemic vessels are smaller, that means this heart has to work harder. And if it can't beat this, then it starts to back up. So you'll commonly see this kind of cycle for your left-sided heart failure patients. We get I'm gonna say the little old lady, because this is who I'm picturing in my head when this happens, but it could be anyone who's got a sick heart. It could be a man, could be somebody who's just a cardiac cripple from whatever. They have some anxiety. And the one that I'm picturing that I've had like 6 or 7 times in my career is they woke up at night after having a bad dream, or there's a lot of stress in their life and something just caused them to get really upset. But usually it's a nightmare that I somehow had. They get anxious, which means their heart rate goes up and they get short of breath. Right? You're anxious, you start breathing faster. Oh my God, oh my God, oh my God, you're kind of short of breath. When you get short of breath, your heart rate is picked up, it starts putting, I said this backwards. You get anxious, so your heart rate increases, that puts more blood into your lungs because they're in heart failure. So that causes them to get short of breath. When they get short of breath, one of the things that their body does is increase their heart rate again, which puts more pulmonary edema in here, which makes them more short of breath, which makes them more anxious. So we end up with this weird kind of cycle where they're anxious, and that anxiety gives them pulmonary edema, makes them short of breath. The more short of breath they get more pulmonary edema, and they get more anxious because they're short of breath. They just kind of keep spinning the cycle around and around. And the way that we fix it is by breaking it somewhere. So we can do things like fixing their anxiety. So I can give them a little bit of Ativan. I can just sit down, take some deep breaths for me, calm down. We can try and fix their shortness of breath. CPAP works well with this, so CPAP actually covers it in 2 spots. Help with their short of breath, get them some oxygen, get them breathing again. And CPAP also fixes this pulmonary edema. The other thing that helps with pulmonary edema is nitro. So when we're treating CHF, left-sided heart failure, we want to use CPAP, nitro, and like nice calm voice, try and get them to relax. And you do those 3 things, and those patients usually they get better almost instantaneously, to the point they'll pick up the oxygen tank and go, come on, let's go. And with their CPAP mask on, and they just pitter-patter off to the truck. They're great. Probably should still go get seen because they were really sick a second ago. But that's how left-sided heart failure kind of ties together. Right side is a little bit trickier to catch, a little bit trickier to treat. The big problem with right-sided heart failure is these guys are often preload dependent and can get hypotensive really quick, which pivots us to cardiogenic shock. So cardiogenic shock is usually heart failure plus hypotension. So it can be like your left heart has failed catastrophically. So maybe you've got like a blown out left ventricle, or you're having a massive heart attack and your left ventricle is not pumping anything. So we're getting crackles in the lungs plus that hypotension. Or you'll see that left heart failure that's causing right heart failure is causing them to get hypotensive. So you'll often see crackles in the lungs plus hypotension, we'll call that cardiogenic shock. Sometimes these guys are described as wet and cold. So wet as in they're diaphoretic and wet in the lungs, and cold because they have poor perfusion. When you compare that to hypovolemic shock, which is dry and cold. So cold fingers because they have no fluid, but their lungs are dry. See the difference? There's a nice little chart, you like look this up, shock, wet, dry. There's a little like kind of square that helps you walk through it and differentiates the shocks. So cardiogenic shock, crackles with low blood pressure. They may not have the JVD that you'd expect in right heart failure because the blood pressure is so low. There's not enough pressure to kind of pop the veins up, but it could happen. How do we treat cardiogenic shock? Carefully, yeah. Sure. After you're done changing your pants, because you're like, oh my god, yeah, this patient's super sick, so we put on our brown pants.
So really cautious fluids.
Yeah, really cautious. What does that mean, really cautious? Can we get a little bit more?
Really cautious fluid admin.
Yeah, really cautious fluid admin. Can we get a little more specific? Like how much fluid? 10 mils per kilogram, right? And when I say 10 mils per kilogram, like I'm about 200 pounds, so that's gonna work out to be about a liter for me if I was in heart failure. You don't take the whole liter bag and go squeeze and push it all in. You give me 250 at a time, and you reassess. Listen to lung sounds, check the blood pressure, make sure we're not getting any worsening heart failure, so lung sounds aren't getting worse, and make sure the blood pressure is coming up the way we want. If they hit a good blood pressure, you don't need to give them more fluid. The whole purpose of giving them the fluid is to get their blood pressure back up. Does that track? Cool. So 10 mils, you're right, cautious fluid. 10 mils per kilogram is the number for it. Beauty. Okay, there was a question on cardiac arrest. You might get a cardiac arrest on your CPSA. Like, it won't just be a cardiac arrest. You might have the patient, though, who has a heart attack or is in cardiogenic shock and then codes. But I wouldn't just give you a code for your CPSA. That would be kind of silly, because we've already tested you on that one. And no, there's no problem. You're not gonna have to terminate on your CPSA. So if you're only focusing on this kind of review for what's gonna be on the CPSA, that's helpful, I guess. But if you're wanting to review, like, when do we terminate? If there's no ALS available after 3 no shock advised, so that's a PEA or asystole, after 3 epi administrations, and the scene's more than 10 minutes away. So you're further than 10 minutes away, you've been running this code for at least 6 minutes, 12 minutes, yeah. One epi every other, so that's gonna be, at least 6 minutes, pardon me. But then you gotta get the pads on, so it's probably closer to 10 minutes. You're running the code for at least 10 minutes, you've given your 3 epi, and you've got 3 consistent no shock advices, then you can call the doc and consider shutting it down. Otherwise, we're transporting to the hospital, or waiting for ALS to get there. So usually after 3 shocks, or 3 no shock advised, we're starting to kind of pack up and try and get moving. Unless there's a reason for the cardiac arrest, hypoxia or something like that. Does that make sense? Beauty.
So if we do get a code as part of the CPSA, you'd be looking for like successful diagnostic work up to that point?
Yep.
For a success
Yep.
followed by.
So if you look on my rubric for the CPSA, a good way to practice for the CPSA is to look at the rubrics. It kind of tells you what I want. So I want you to do an assessment of a cardiac patient. You can't really do that after day. But I could have so you will have to do an assessment, whether that's pre-cardiac arrest or post. More likely gonna be pre if I'm gonna do it. So you'll assess your cardiogenic shock patient, you'll do all your good stuff. While you're doing differentials, the guy drops, goes into full cardiac arrest. I'm expecting that you can recognize cardiac arrest, get your partner to start CPR right away, like defibrillate appropriately, all of those things. But you will have a patient at some point who will be somewhat awake and can answer your questions. Cool. And then I just did a nice little table because a couple of people asked me for cardiac specific treatments. I think it's all the stuff we've talked through. So stable angina, unstable angina, O2 aspirin, nitro as needed. IV access if we're taking them to the hospital, serial ECGs. So that helps us figure out, are they the end STEMI or are they like growing a STEMI? Are they starting to have those ST changes? And then we're gonna get them to a hospital or a cath lab. So folks who go to Nova Scotia, you'll often bypass local hospitals and go right to a cath lab. Anyone's going to Fredericton? I don't think anyone's going to Fredericton for replacements. That might be something you'll run into too, where you skip the closest hospital, St. John's, what I meant. You'll skip the closest hospital and go right to St. John Regional, because they have a cath lab there. Same thing with the occlusion MIs. Pulmonary embolisms, O2, consider aspirin and nitrile. If you're unsure, it's not a clear PE, you might want to consider those. They may need CPAP if you've got some heart failure going on, and we're just driving these guys to the ER, so it's usually just oxygen. Your CHF, we just got ran through, O2 through your non-rebreather, nitro while you're getting your CPAP ready, so a spray of nitro while the CPAP's getting set up. Apply your CPAP if they're awake. If they're unresponsive, we're thinking more BVM and PEEP. Everyone know what PEEP is and how that works? UT? No, if you don't?
No, it's in this device.
Okay, great, okay. CPAP is constant positive airway pressure. So that means when the mask pushes, when I breathe in, the mask is pushing 5 centimeters. And when I breathe out, it's also pushing at me 5 centimeters. BiPAP is just 2 different numbers. So it could be breathing in 5 and breathing out 3. So when we have BVM with a PEEP, we're actually more likely we're making BiPAP. Whatever pressure we're squeezing on the bag, we don't know, really can't measure that. We don't really know what that is. So that's X, and then whatever we set our PEEP valve to, that's what they have to breathe against. Does that make sense? And we don't put CPAP on people who are unresponsive. If people fail to CPAP, so don't do that. And then cardiogenic shock, we just talked about 10 mils per kilogram. If your pulmonary edema gets worse, or starts to show up, or your blood pressure gets to where you want it to be, then you can stop the fluid.